Now we'll discuss about the clinical correlates of the conjugate eye movements and the neural regulation of this conjugate eye movements, any of the damage or any kind of things we'll discuss now. So let's get started. Firstly, if there is injury to MLF. What was MLF? That was medial longitudinal fasciculus. Okay, that is if there is unilateral damage to the MLF, only one side, suppose right or left. Okay, if we talk about the right side, if there is damaged, then there will be RMLF, MLF syndrome. That is right side of R is right, medial longitudinal fasciculus is damaged, RMLF syndrome. What happens in the right MLF syndrome? Here if we see, this is right side and this is the right MLF. So if this is damaged, that is RMLF syndrome, if the right MLF is damaged, what will happen? What the right MLF does? So suppose this is activated through this, okay, through this is activated, and then through this, the sixth cranial nerve activated, and this left eye will move, this left eye lateral rectus is working, okay, because of sixth. So this left eye will move towards the left. Now what would happen? This pathway isn't damaged, okay, so this eye cannot move medially, as it will supply the third oculomotor, and oculomotor supplied medial rectus. So medial rectus can't get the activation through this nucleus, can't get activated through MLF because it is damaged. So this right eye cannot adduct. This eye will abduct, move away, but this eye cannot adduct. This is also known as right internuclear ophthalmic plasia. This is right internuclear ophthalmic plasia because internuclear that fasciculus is damaged. So what would happen in right case? So this is right eye, this is left eye, okay, if this right MLF is damaged, okay, if right is damaged, like this MLF is damaged, then this eye cannot adduct, okay, its third cranial nerve is not getting the supply, and third cranial nerve is supplying the medial rectus, so this eye won't look towards the left, but here sixth cranial nerve will activate and it will look towards the left. So this kind of if he wants to look left, this kind of eye double vision, he will have a double vision, this kind of vision he will get, like two images he will get, okay. So if now this was right, if we talk about the left side, if there is left MLF, that is left side medial longitudinal fasciculus syndrome, this is syndrome, or what can happen? This is left internuclear ophthalmic plasia, left internuclear ophthalmic plasia. This is now in this case what happens? Left side, this one isn't working. So if this is activated, then this eye, the right eye lateral rectus will abduct through this, okay, through this the sixth cranial nerve supplies what? It supplies the lateral rectus, so it will abduct, but it is not able to communicate with this or contralateral third cranial nerve, as left MLF is damaged. So this through third, its medial rectus, this won't work, so it will not be able to adduct his eye in left. So what kind of vision you'll see? Here also you'll see a double vision. Here what kind of vision you'll see? The left eye, left MLF isn't working. So if left MLF isn't working, then this side medial rectus isn't working, so it will look like this. Here lateral rectus is working, like sixth cranial nerve, so it will look. So if he wants to look towards right, this is if the left MLF is damaged and he wants to look towards right, then this will happen. If this person who has this LMLF, that is left medial longitudinal fasciculus, is damaged and he wants to look towards the left side, so if he wants to look towards the right side, left side, so this here sixth cranial nerve is stimulated, then it will look towards the left side, and this will connect through right MLF to the third cranial nerve, and its medial rectus is also, because its right MLF is working, So this person can look towards the left normally, but it cannot look towards the right normally. Okay, so if he has left MLF, okay, then that person can look towards the left normally, but the contralateral, like right hand side, if left is not working, then right hand side. If left is not working, then that eye cannot adduct. Okay, so whichever right side, if MLF is damaged, then it cannot adduct. If left, then it cannot adduct. So this is a adducting problem. Okay, abduction is normal. If you see about abduction, the abduction is normal, but the adduction cannot happen, because adduction happens through third cranial nerve, and third cranial nerve should be connected through the MLF. Okay, this abducting eye, here also and here also, the abducting eye, which is this abduction means out. Okay, adduction means inward. This is adduction, this is abduction. So this is this abduction movement will show a jerky movement, like it will move like this, show jerks. Okay, this will show to and fro movement. This to and fro movements and jerks is known as nystagmus. Nystagmus of the abducting eye. There can be unilateral injuries to the MLF, that is right or left, that may be caused due to multiple sclerosis. What happens in multiple sclerosis? The multiple sclerosis is a demyelinating of central nervous system neurons, or there is infarction, tumor, infection, something. And bilateral MLFs can also be damaged. That is what happens in bilateral. Bilateral means in both MLF is damaged. So this kind of condition won't be there. Like if he wants to look towards the left, then this eye will abduct, but this cannot. If he wants to look towards the right eye will abduct, but this won't adduct. Means there will be no adduction in either direction. It cannot look properly. Like in bilateral vision cannot be possible if he wants to look towards the either side in bilateral lesions. In bilateral internuclear ophthalmoplasia, okay, that is right internuclear ophthalmoplasia. If both is, that is bilateral internuclear ophthalmoplasia. That is larger stroke or bilateral demyelination. Bilateral demyelination is also known as Wernicke's encephaly. Can be caused by Wernicke's encephaly. Bilateral demyelination can happen in Wernicke's encephaly. What happens in here? There is thiamine deficiency. Thiamine, vitamin B1. There is that deficiency. As B1 is considered to be used for acetylcholine synthesis and nerve impulse transmission, it is used. Okay, so in this case there will be bilateral demyelination. One more problem can be there. If there is a larger pontine lesion, then this space can be covered under lesion. Okay, this hole, that is in here. What happens? The PPRF is damaged, ipsilateral MLF is damaged, contralateral MLF fibers are damaged, and sixth nerve nucleus is damaged. So there are a lot of damage if this spot is damaged like this. So here left hand side this lesion is there. That is through sixth cranial nerves. This is damaged, so that is the lateral rectus will not work. That is, this eye cannot abduct. Here this MLF is also damaged, left MLF. So that is this supplies medial rectus. So that is, this eye cannot even adduct. So there is neither abduction nor adduction of this ipsilateral eye. This is damaged, then left eye won't move. And through this MLF is damaged. That is, this eye will not adduct. Okay, because third is connected to the medial rectus, so this will not adduct. It can only abduct. Okay, the right eye abduction is intact. So here one eye cannot move, either abduct nor adduct. Abduct. But this eye can adduct. Are you getting? So this kind of syndrome where one eye whole movement is lost and half movement. So that is 1.5 syndrome. This is 1.5 syndrome. That is where there is a damage, where there is this whole damage. Ipsilateral eye will not adduct or abduct, okay, and the contralateral eye will only abduct, okay. Third one is if this cortical centers are overstimulated. Suppose right cortical center is overstimulated, then what will happen? What it does, I told you, when this is stimulated, the eyes will look towards the opposite side, like saccadic movement. How this will stimulate this will stimulate this will this. Lateral rectus, this will move toward this side, and through this right MLF, it will stimulate the medial rectus, it will move towards left side. If this is stimulated, the eyes will look towards left side. So if it is overstimulated, the eyes will look towards the opposite side, it will look away. But if this is destroyed, then this will work and this will look towards it, okay, because there should be two equal action, okay. If this is working and this is not working, this is destroyed and this is only working, if it is destroyed, then eyes will look towards the destruction because of this contralateral frontal eye field, because this eye field wants the eye to move away from it, okay. These cortical centers, what they are for, they initiate the voluntary horizontal saccades, okay. They initiate the horizontal voluntary saccades. So for this purpose they are used, okay. So this was about the clinical correlates. Thank you.